Child Welfare Virtual Expo 2017. Session title: Assessment and Decision Making in Cases with Co-Occurring Disorders. Sherry Levesque from the Capacity Building Center for States speaks. Behind her is the Child Welfare Virtual Expo 2017 logo and the Twitter handle #CWVE.
Welcome back. We hope you enjoyed the interactive virtual chat session and the Innovations in Child Welfare Practice exhibit booth. As a reminder, if you can see us but you can't hear us, you may try turning up your computer speakers, or if you need additional assistance, the help desk is available. We're pleased you could join us this afternoon and look forward to sharing information with you regarding assessment and decision making with families with co-occurring issues. With me today to provide their perspectives on this topic are Kim Bishop-Stevens, Manager of Substance Abuse for the Massachusetts Department of Children and Families, Denise Moore, Family Consultant with the Center for States, and Dr. Nancy Young, Director of the National Center on Substance Abuse and Child Welfare. Just a note about our session today. While our discussion may focus at different times on one particular issue, either substance abuse or mental health or domestic violence, what we're really intending to highlight is the importance of collaboration when any combination of these issues are present or when they are present individually in a family's life. To do this, we plan to look at a family's involvement with the child welfare system from the point of initial investigation through case planning and all the way to case conclusion. In addition to a polling question, we'll be asking you to consider some reflection questions at a couple different points during the session. And when we get to those, we'd like you to just jot down some thoughts in response to each question, either on the handout that's provided for this session or on some paper. We'll be discussing these questions and answers during the virtual reflection portion of our workshop later. And you'll find the handout for this session in the chat pod on your screen under the Handouts tab. Denise, we really appreciate you being here to share with us this afternoon, and I'm hoping you might be able to tell us a little bit about your family's initial involvement with child welfare.
Thank you. Good afternoon. So I'm Denise Moore. I am a service area coordinator for the Parent Partner Program in the state of Iowa, and I'm also a family consultant for the Center for States. But most importantly, I am a mother of 6. In 2003, all my children were removed due to my substance abuse issues. I had been using drugs since I was 12 years old. I come from a world of trauma, domestic violence, sexual abuse, and I learned very young how to hide my pain. When I first came into the system, I remember being so scared that I was never going to get my kids back. I knew that that they were going to be removed. I had been arrested for conspiracy to deliver methamphetamine, and we were so scared about DHS coming into our life that they literally had me bonded out in minutes. We were more scared of the Department of Human Services than we were actual prison system. So they got me out, and sure enough, the department came to my door. I had an amazing worker actually who seen my kids and what was for the best interest of them. And in 2003, there wasn't a whole lot of relative placement, but my mom was allowed to move into my home, and I needed to move out. There was literally no assessment of my needs. My case was pretty cut and dry. I mean, I was a drug addict. That's what they seen. And at that time, we got case plans in the mail. So that's literally what I had. I had a case plan and an idea of where I needed to go. I knew probably treatment was somewhere down the road, but I didn't know how to access it. I wasn't engaged in any kind of dialogue on how to really navigate them services or any kind of assessment of any other needs at that time. And then, Nancy, do you want to speak to maybe what you've seen in different jurisdictions across the country around assessment?
Yeah, I think in that point in time, that wasn't unusual. I think things have changed in many jurisdictions, and that's very encouraging. The National Center on Substance Abuse and Child Welfare originated about 15 years ago. And one of the very first questions that we started to get multiple times, what is the right screening tool that we could use? Just give us a few questions. We don't want to change our whole child welfare assessment process, but could you give us 3 or 4 questions that we could insert into the way we're doing assessments? And that was almost like they wanted a silver bullet, that was going to then be the answer that would determine that this is a family who needs assessment, who needs to be engaged in substance abuse treatment, and that was going to be enough. So we set out in a process to try and figure out, what's existing in terms of screening and assessment tools. We developed a monograph that we'll talk about today called Screening and Assessment for Family Engagement, Retention, and Recovery. And that key part of that is for family engagement, retention, and recovery. Because what we began to learn very quickly is that it really depends on what the purpose of having that protocol for screening and assessment is. If it's about documenting a case, that's very different than those words for screening and assessment for engagement, retention, and recovery. So we learned many things during that process of developing that tool. Important was about the need to really partner with the experts in the substance abuse, mental health, domestic violence field to bring that expertise into child welfare practice and into the court system, so that there was really a partnership and that we were drawing on the expertise of that system as well as the expertise of child welfare. We also learned that the screening tool wasn't maybe always necessary, and we developed what we refer to as the 4 prongs of screening that we're talking about. Sometimes we do need a universal screen, and we see great success in communities and states that have established protocol about this is the screening tool to use, and where to document that in the case record as well as in the information system. But sometimes you don't need a screening tool. If it's an infant with prenatal substance exposure, you probably aren't going to go to the hospital with your 5 or 6 questions about screening for, is this a mom who needs help with a substance use disorder? So many jurisdictions have developed signs and symptoms checklists that when they're doing their initial investigation or their home visit, they're looking for these signs and symptoms in a way that says this is a family who needs help with this particular condition. The third is corroborating reports. Sometimes you've already gotten that in the initial report and the initial hotline call that's come in, but sometimes it takes actually talking to the other family members and really understanding what's going on in the life of this individual who may be struggling with that substance use disorder. And then when it's appropriate to conduct a random urine drug screen to determine that that's something that can be an engagement process also with how that is administered. But what we think is really important is what is that clarity about the purpose and about the team that needs to come together for that. What we find in most jurisdictions that they begin to work on this kind of process of changing their screening and assessment is that they figure out a way to bring that expertise into the child welfare system. It may be a very different model from place to place. Sometimes it's a person in recovery who's paired with a child welfare investigator and they become a team. Sometimes they have specialized counselors who are a unit that have a referral source from CPS or from the Child Welfare Agency to this unit of substance abuse specialists that are engaging families in care. And then sometimes it's the person who is outstationed in the CPS office that becomes more of a consultant kind of role to child welfare. In all of those cases, it becomes very important to have those collaborative processes worked out in order to have the good communication. You'll find a link to that monograph, Screening and Assessment for Family Engagement, Retention, and Recovery, in the chat pod that's under the Handouts tab. When we look at what's in that screening and assessment book, we call it SAFER. There's a few different sections. Important first is about how you build that collaborative, how you find the right professionals that need to be brought in for your particular jurisdiction. Really critical is about those collaborative roles and responsibilities. You can't get to advanced practice of collaboration unless you're very clear about who's supposed to do what. And having that clarity just helps with things that happen down the road to say who is responsible for that particular facet of the case planning and the monitoring. The third piece is about putting that collaborative practice together at the front line. There are lots of fact sheets and worksheets in SAFER about how to build these models. There are also appendices of actual screening tools. So what is used in substance abuse, mental health, what is used in child welfare to look at safety and risk assessment. But Kim, you've been operating some of those models in Massachusetts. How are you supporting staff in doing some of those roles and the assessment with families?
Well, in Massachusetts, what we've developed over time are 3 clinical specialty units in substance abuse, mental health, and domestic violence. These are state employees of the child welfare system, and they sit in our regional offices and provide consultation to our area offices directly. They also have a management structure in our administrative offices as well. So those units are there to support our staff with case consultation, to enhance skill development for staff, provide cross-systems training and training to staff, as well as work really closely with our community partners, because that's always been a challenge, just to make sure that we're connecting for families with their providers and community members that are supporting them. In the last 2 years, Massachusetts has also updated their intake and assessment policies at the front end of the system, and the clinical specialties participated in the development of those policies to take a look, because as you said, it's not just about the screening tool, but looking at all the different areas that we need to really embed in our policies to make sure we're assessing all families, because families often come to the child welfare system with multiple challenges, and to make sure that we're kind of addressing those at the very beginning. To support that work, we embedded information into our data and IT system to make sure not only that we were going to capture the data, but that information wasn't lost as families move from through the system. So at intake, not just what the report was about, but looking at all areas that are challenging to families and how that we can support those and develop services around those. To best support our policy, we also developed clinical practice guidance. We found that workers really struggled how to ask families some of these challenging questions, particularly as it wasn't related to the mandated report, and to go beyond and ask all families about these sensitive areas and how to do that in a way that was supportive and engaging to families, but also provided us with the kind of information that we needed to best service plan for families. Part of this guidance really looked at areas to consider, things to look for in the home, as well as very specific questions that workers could ask parents, family members, children, and also providers working with the family. Since workers don't always have the right questions and words to use, we try to give them some very specific information to do that. We did this really together, integrated our teams for substance abuse, domestic violence, and mental health, sit together at the regional office and administrative offices, and do this work in an integrated fashion. The other piece that we did was really help our stakeholders understand our policy changes and updates and the kinds of things that we might be asking at the front end of the system to best understand where families are and the kinds of services that they may need if they're involved in the treatment system, and how we can be helpful in that. We provide them with cross-systems training, as well as continuing to train our workers on the services that are available and what to ask them.
Sherry, I'm going to turn it back to you so we can get a sense of what's happening in other communities.
Great, thanks, Kim. Now let's take a look at some of those virtual reflection questions we mentioned earlier. There are 3 questions that we'd like you to think about and consider what you've just heard and how it applies to your agency. And again, as I walk through each question, I'm going to pause and let you jot down some thoughts so that you can refer to them later. So the first question is, how does your agency or community currently assess issues of substance abuse, mental health, or domestic violence during the initial investigation? what components of the four-pronged approach are in place in your community? Lastly, what policy and practice changes would be needed to implement the four-pronged approach? So take just a few moments to finish up your thoughts. Okay, great. Now let's turn to a quick polling question to start us thinking about how we know when a family is making progress in case planning and service provision. So we'd like you to think about and answer in the poll, how does child welfare measure success with the case plan or with the treatment plan? Is it through completion of a treatment program? Or is it through regular participation in counseling? Is it measured through regular participation in support groups or other supportive services? Or is it really all of the above that indicates success? And we'll give you just a few moments to respond to the poll.
Nancy speaks.
You know, some of those options, I mean, we often find that child welfare is perhaps the treatment agency and the timing of what's happening in the case plan and the treatment agency is perhaps not in sync with the child welfare case plan. And that's one of those indicators that we like to see about how the systems are coming together to sync the phases of treatment to make it make sense for the parent in what's happening in their case plan. When they operate in isolation, it becomes just confusing for everyone, I think, including the parents, about what they're actually looking for success. The other thing I would comment about some of those options while we're waiting for the polling results to come in is really the movement in substance use treatment, the field, to move away from this idea of treatment being a one-time event. We recognize that substance use disorders are chronic diseases and that we need to take a chronic disease management approach. And so in some jurisdictions, they've moved away from the idea of a graduation, particularly in family treatment courts, that it is a phase that you have completed and you're moving into active recovery, and that the paralleling those phases with the case plan becomes so important. So all of those things are things to look for, but really recognizing that this is a disease management approach that doesn't depend on one event to say this is success. It's about looking for patterns of behavior over time.
Oh, and Nancy, it looks as though a majority of folks, in fact, quite a large percentage, I would say 95% of people responded with all of the above. An answer to the poll. It looks like 4% felt that completion of a regular treatment program was the measure, and 1% felt that participation in support groups was the measure. But the majority of folks certainly did think it was all of the above.
Mm-hmm. And that's what we often see. And I just would ask that folks think about, if we were managing another chronic disease, what would those indicators be of success? And that it wouldn't be like the emergency room visit or a broken bone that is a time-limited phase that the bone heals and you don't expect to have chronic condition or a chronic kinds of thing that needs to be managed. That's not certainly to say that someone stays in treatment forever, but that it's about that phasing of independence, of structure, of recovery, and what does that mean in the context of safety and parenting skills and the ability to safely care for your children. So syncing those things together about what does recovery mean becomes so critical. Denise, what was that like in the next phase for you in your child welfare case plan in your family?
Well, I think I found it interesting that you said the treatment center shouldn't be acting in isolation of the other providers, because that is exactly what happened in my case. There was literally no communication between my caseworker and my substance abuse provider. Through that process, I kind of languished in the system. I literally was lost and looking for somebody to guide me, show me the way, show me how to live life in recovery. I couldn't imagine ever being clean. I had been doing it for so long, and it was so embedded in how I was raised and grew up. So I needed that kind of support system. I needed and some accountability, I think, because it was very easy to deceive people when they're not talking to each other, I guess. But that's exactly what happened. And then when also I did, some of my other needs, trauma, mental health, domestic violence, was never addressed. I mean, I had been beaten unrecognizable in front of my children. The same thing had happened to me when I was a child. I had seen the same thing that happened with my mom. And none of that was ever asked. And I was too scared to tell anybody what was really going on with me. And so that kind of perpetuated my case. I think if everybody would have been working collaboratively through that process, I would have had a much quicker case, but instead I was looking at termination of my parental rights. My worker made me sit down and line all my children up. When I came into the system, I was pregnant and I had 5 children at that time. And she had me line all my children up, from my very youngest 6-month-old baby to my oldest 15-year-old son. And I was going to have to tell them that I was going to lose them forever. And my son looked at me and he just loved me. I mean, he was like my little road dog. He was my guy, and he loved me. And my kids didn't want to be around anybody else, but I mean, they wanted their mom, and they thought I was going to do it. And I had to tell them that I was losing him. And he looked at me with this face that I will never forget, that I was choosing drugs over him. And I broke his heart. That was like a turning point for me in my case. That kind of defined who I was and sent me into a different direction. Do you see, Nancy, sometimes across the country where we're so far into the case and there's no engagement until termination of parental rights?
We do see that, Denise, but I just want to take a moment and say thank you so much for sharing your experience, because that pain that we're feeling, your pain as you share that with us, and the pain of your children, and how important that was in your life, and knowing that your story now gives all of us hope about how things can be different. We do see jurisdictions that are changing the way they're doing their screening, their assessment. And again, the purpose of engaging families in this change process. So just thank you so much for that. It really, I think, touched all of us for sharing that, and how much hope that you give to us about what recovery looks like, and that recovery happens. We know from data that the second most frequent reason that's given for termination of parental rights is parents' drug problem. And that's just, it just is not the way things should go when we know that there is hope and there is recovery, and that it's incumbent on all of us to make that possibility for parents whenever we can. There are different models about how jurisdictions around the country are doing this. I think most people have heard about family treatment courts that take a non-adversarial approach to the case, that the court and child welfare treatment, mental health, other agencies are working together in order to make sure that the service package is understandable to others, to the family, to each other, and that there's a way of holding the system accountable as well as the parents and the family members. We've talked a little bit about co-location already. What's really key, it seems, is the ability to have cross-training. The National Center has resources available that are free training packages that are web-based that we hope that lots of places around the country are using. But that opportunity to have that understanding of the other systems. So if you're even if you're a frontline worker, even if you're a supervisor, and you might say, well, gee, I don't have the ability to really change policy in my state. I'm at the front line. I would really encourage you after this is to pick up the phone and call your domestic violence shelter, call your substance abuse treatment agency, go visit. I think there'll be open arms to say, this is what we do. This is how we begin to build those bridges between systems. So those models are really important in terms of how the collaborative happens. There are a few things that we see are sort of the key ingredients at the front end of the system that would change that would turn that on its head, so that we're doing this in the beginning and not waiting until a parent is facing termination, and that the children have been through the trauma of removal and what's happened to them during that time period. So turning that on the head means that that there is a standardized way in which early identification is happening, be it the four-prong approach, but that we're not waiting. It takes buy-in from parents' attorneys. It takes buy-in from the children's attorneys. But what would it be like if on that first day, parents had somebody that was offering the hope on that first day of realization that their child is going to be placed in out-of-home care? Many years ago, my husband and I became adoptive or foster parents, and on Friday afternoon, our birth mother asked the social worker for help to get into treatment on a Friday. And I think that it happens differently in different jurisdictions now, but some 22 years ago, the caseworker said, I don't have my list of resources with me today, and I'm off on Monday. Call me Tuesday. Now, I think all of us could say that probably didn't happen, that our birth mom was able to get through that weekend without that pain that you were experiencing, and her coping mechanism of using. How did that possibly think that that was reasonable efforts at that time? Absolutely, it met the letter of the law. But what's reasonable, we know now with the brain science of addiction, is making sure that we're bringing that hope, we're bringing that screening and assessment process into the very beginning of that case. So some way of identifying early on. The second really key ingredient is that timely access to treatment. And that means working collaboratively with the agencies to make sure that there's a way that parents can enter that door when they're ready. We know so much about what happens when that parent says, like you did, I know I had to do something. There is a moment of clarity that said, I need to do something different. Are we responsible in a way that we're shoring up that family to make sure that timely access happens? But what we've learned over the last decade in particular is that timely access is really just not enough, that it really takes some system of recovery support. When we think about CASAs for children, if you think about what a parent needs in order to get from that moment into engaged in substance abuse treatment. Different models again of that, parent partners, recovery coaches, mentor moms, all kinds of different ways that jurisdictions are configuring that and coming up with a way in which they're able to put that enhanced recovery support, increased outreach, the go-get-em strategy when someone doesn't show up. We know that's often driven by trauma. We know that's often driven by shame and guilt. What's the go-get-'em strategy when that happens? So those are a few of the key ingredients. There are some more. But Kim, how's it working in Massachusetts about those kind of models when you're looking at family reunification? Actually, I think, but if I think just for a moment about that next phase of family reunification, the types of integrated models that I talked about and how those systems come together, that it's important that that assessment process go all the way through the case, that it's not just at the front end that I've been speaking about, but that assessment is a process, and that there has to be a way in which there's good communication about monitoring changes in treatment, about monitoring changes in progress, and how that gets communicated. What's key, I think, is having a real system of roles and responsibilities. Again, that accountability for the systems as well as accountability with parents. And you can't do that unless we know what each of those collaborative partners are supposed to do. In many of the communities that we've worked in, they've been looking at ways in which they're clarifying the patterns of behavior that are communicated back to the parent's attorney, the child's attorney, the child welfare office, so that a treatment agency is reporting often on a twice monthly report. Some communities call them twice monthlies. And what that means is that the treatment agency has worked out with all of their partners what is it that's critical information to be communicated on a regular basis. So sometimes it looks like how many sessions was the parent to attend, and did they? Meaning treatment sessions, mental health counseling sessions, how many times were they supposed to meet with their recovery mentor, and did they? How many times were they to attend a mutual aid support group, and did they? And then how many times were they supposed to test, and what were the results? So if you think about that, if you're a caseworker getting ready for a 6-month review hearing, and you've twice a month gotten this information about how a parent is doing in services, you have several of these twice monthly. So you're really looking at that pattern of behavior, not the one time perhaps that someone uses again. It depends on if they're using and getting back on track into that pattern of behavior, or is this a return to adverse consequences despite their use, or connected to their use. So that pattern of behavior becomes really critical about how we look at that readiness for reunification, and how we create those communication patterns to make sure that that's happening. We think that that's really one of those key ingredients in the system, is to clarify those roles. Again, the Safer Monograph has worksheets to help you do some of that and to establish those communication protocols. And now, Kim, how about if you tell us about Massachusetts?
With the development of our specialty units in Massachusetts, their major role is to provide case consultation to workers, to really look at challenging cases or areas where workers are really getting stuck with families and not sure what next steps are. We do that both individually with a worker and a supervisor, but we also do that part of integrated teams. So when families are facing multiple challenges, we might have the domestic violence specialist, mental health specialist, and substance abuse specialist sit together with a worker to think about the resources and what are next steps for the families. What are we really worried about? What are some of the high risk factors that we need to really be considering? We might even work with that worker directly to make that connection to the community providers, as you were saying, Nancy, how that connection is so important, to make sure a release is signed. And sometimes our workers aren't always clear of what they should be asking treatment providers, or sometimes our treatment providers don't always respond to our workers' requests for information. So even helping them make those connections is really important. And I think for our workers, it's also going beyond asking the questions, but how do they get engaged with families, and how do they really get this information? Most families aren't really wanting to be very open with their DCF worker, concerned what a relapse might be for their kids and what's going on with their case. And so really being clear about how we do this in an integrated way and how we engage families so that we can have these open conversations and try to best understand what's happening for families. we use the information we get from Consultation to think about what are the training and skill development that our own staff need in child welfare, what are the common questions that we get, what are the areas that they have concerns around. With the opiate epidemic affecting Massachusetts, there's been a lot of concern from staff now about overdose prevention, medication-assisted treatment, questions related to that they need real specific help with in terms of understanding next steps and what are the risk factors related to the opioid crisis and where to go next. Whenever possible, we try to do this training with the clinical specialties coming together and providing really an integrated training to staff. We also need to think about how we partner, as you said, with our community providers. And one of the things that we did 2 years ago in Massachusetts was to update our releases of information. We often hear from providers that they're not using the right release, or we can't communicate because there's not a release in place, and really trying to go beyond the communication challenges that really are somewhat solvable if we can make some agreements on what the releases need to look like and what information we should be sharing. So we updated our releases of information and really worked with our sister state agencies on what those releases should look like so they can be accepted, that they meet state and federal laws, with 42 CFR for substance abuse treatment providers, making sure that the release was compliant with that federal law. Then we, as an integrated team, went around to our area offices to provide training on the releases. Which releases to use for which providers was really important for our staff to know, as well as how to fill out the release. So there wasn't these barriers in place where they weren't getting the right releases because they didn't have the right language on them, and that staff were filling them out correctly. And then we really moved beyond that in terms of talking about what information do we need to know from providers. A lot of times our staff was getting from treatment providers that a parent is compliant in treatment or engaged in treatment, and the conversation would end there. And we would say to our workers, well, what does that really mean? And the workers would say, I have no idea. And so that might mean that they're coming just for their treatment. But it wasn't helping us understand, were they understanding their triggers? Did they have better insight and those behavioral changes that you're talking about? And that to really have more information about that. How are they looking at stress differently? Are they making what does progress in treatment look like? And that's something that we're still working on with all of our providers, is going around and having those conversations so that we can have this shared dialogue for families and make sure that we are addressing the areas and partnering with our sister agencies and providers. The other thing is also looking really closely with the systems about what needs to happen on their side. So our Department of Public Health that oversees our substance abuse treatment providers a couple of years ago updated their intake system so that they were asking families, are you involved in child welfare? A lot of times we'd have a parent go in for treatment and they wouldn't be clear that child welfare was involved, so that they didn't even know to ask for a release. Do you have children, and are those children living at home? So they were updating their MIS system to better capture that information, so we knew how many parents we were treating in treatment. And they updated their licensing requirement that said to substance abuse treatment providers, in order to have your licenses, you have to have continuing education requirements around family-centered care. What is the impact of substance abuse on parenting? So that is a new requirement that treatment providers really need to make sure staff have a better understanding so that we can have better communication and collaboration. For our domestic violence programs, they really had to start thinking about not just survivor services, but child-specific services. So they weren't just looking at treating the survivor and working with the survivor, but thinking about what is that impact of domestic violence on children, and how can we have child-specific services to support the children and the families. Our domestic violence unit also works closely with the community health centers and our hospitals, as they are often, some of the times, the first line of intervention for families. It might be the first time that somebody is getting treatment, to think about how do they safely gather this information, when does child welfare need to be involved, and how can we do that safely so we're not increasing risk at the beginning if they're getting involved in child welfare, and making sure that that's part of our partnership. I think one of the challenges that remained is not all of our service systems are integrated. So oftentimes families have multiple providers and services working with them, and each of us have our own lens of how we're looking at the family and might have our own lens of what we see happening. And so I think the importance of really thinking about whether it be family team meetings or places that we can bring all providers together to get a full picture, because I think that has been a challenge, is there might be many providers involved, and how do we all come together to have a shared understanding of what's happening for the family and what are the next steps. And I think as we're thinking about case closure, it's really important to make sure all of the partners working with the family really have a good sense of where things are and would know when to involve child welfare again, and make sure that we're also partnering with families to say, what do things look like when they're not going well? And what would be those next steps? And who would you reach out to so that we can make sure that we have successful case resolution? And if there needs to be child welfare involvement in the future, that we also have a plan for what that may look like.
Sherry, I'm going to turn it back to you to talk again about what's happening in other communities.
Sure, and thanks, Kim, for sharing those insights. Let's take a final look now at some additional virtual reflection questions. Again, we'll have 3 questions for you to consider and think about what your current practice is in your agency. And as you think through each question, I'll pause again and let you write down some thoughts to reflect on later. So the first question is, who is currently involved in case planning with families involved with your agency that have some combination of substance abuse, mental health, or domestic violence challenges? And how are those services coordinated at your agency? And how can your agency align the case planning and service delivery decision-making with those substance abuse, mental health, and domestic violence partners in your community? And lastly, what did you hear about in today's session that will help you solve any existing barriers to collaboration? So if you would just jot down your final thoughts. Okay, thank you. And Denise, I'm wondering how things ultimately turned out for your family.
So after I left that meeting, God pretty much said, you're gonna have a flat tire too. And so, and I ended up at a gas station and literally cried for probably the first time in my life. I cried for everything that I had been through as a child, everything I put my kids through, what my kids were going through then, and really gave it away. I surrendered, and I needed help. I went in. We had a family team meeting. Family team meetings were just starting up in Iowa at that time, and we had a family team meeting, and we brought all the providers together and the attorneys, and my family was all there. And for the first time, everything was out on the table. And I remember my attorney looking at me and saying, well, you need to be able to find a placement or for your baby because she's adoptable. And I was just like, just give me one more chance. I just need one more chance. And I had an amazing worker who let me have another chance, who's seen something in me that I didn't even know I had in me. And I've seen a lot of families get terminated on much, much less than what I did. I didn't use drugs anymore, and I was not happy about it because I needed to build them relationships. So what I've heard today of how much that team approach is, and working together and building trust-based relationships is so critical to families. I didn't have that. I come from a world where nobody trusts anybody, and I was really starting to build relationships that were impacting my life and making me change. And I was able to trust people within my team I started building relationships with them in my community, my recovery community. The women would come and pick me up and take me to AA meetings and NA meetings, and when I started isolating, or they'd come and they'd be pounding on that door. So I love what you say when we talk about recovery coaches and peer management, because families are scared. They're scared, and they're scared of change. They're scared of not change. They're just, they're petrified. And what I love about our work in Iowa and all across the nation with recovery coaches and peer mentors is that they're helping them navigate the child welfare system and be able to say, okay, these are some services that I need, that is critical to my success. At that time, the Parent Partner Program started to come in. It just started in Iowa. It was an amazing turn of events. So started in Iowa, and I started going back to school to get my degree. And I remember everybody's like, "Oh, you can't go work in child welfare. You better go get yourself a substance abuse degree so you can get a job." And I'm like, I want to go back and help families. I want to go help. I want nobody to feel alone like that and scared and vulnerable when they come into the system. And lo and behold, this AmeriCorps position opened up, and DHS gave me an office. I was like, crazy how things turn out. And so I was able to work with families at that point and work on disproportionality in our community, Partnership for Protecting Children program, and went on, got my degree, became a coordinator for the Parent Partner Program, and now I provide oversight for 15 counties in our state for parent partners. And I can tell you, when I look at the work they do every day with families, it really truly is inspirational. And the way you mentioned the treatment teams, we have very strong recovery courts in Iowa, and our providers work together to support families and lift them up, and it's really amazing to see, and being able to just meet them where they're at, and believe in them. Every single successful parent, I think, that I've ever talked to has always said there was one person that believed in me, and that always sticks with me. So the changes in my family, my kids have broken the addiction. They've broken the cycle of addiction. They don't do drugs. They've graduated from high school. They're getting their degrees. They have beautiful, amazing relationships. They're buying homes. I don't know where they got all that from, but I think that through it all, families are resilient, and my kids being able to stay together and watch me change has helped them to be able to not go into that same cycle that I did. Today I get to do amazing work across the nation and with the center, and I am just truly, truly honored to be able to go and work with different states and jurisdictions on impacting practices and policies that really truly engage families at the very beginning through that process. Because I remember, that assessment and that shared decision making was critical at the end. And if I could have had that assessment piece at the very beginning and really identified what my needs were and be able to be connected to the services that were going to help me, I think I would have had, I wouldn't have probably been in there so long. It had been so close to termination. But so I'm really honored and grateful to be here and be sharing with you all. And I think I'll hand it over to you with those.
Sherry speaks.
Yes, and thank you so much, Denise, for sharing your story. It's so helpful, I think, as we think through these challenges. And thanks to you also, Nancy and Kim, for sharing your insights on these issues with us. We're now at the end of our presenter remarks, and we'll soon transition into virtual reflections. And this will be an opportunity to reflect on and chat about what you just heard with our panelists here, as well as your fellow participants. So in a moment, your screen will change as you're automatically moved into the virtual learning lab. Following our virtual reflection activities, we ask that you share your feedback by please completing our session evaluation. And please then plan to join the virtual chat session in the Indian Child Welfare Act booth in the exhibit hall at 3 p.m. Eastern Time. And our closing session, Resolve and Recommitment, a Call for Candor, will begin at 3:30 p.m. Eastern. Thank you for your participation in this session, and we look forward to chatting with you in the Learning Lab.